Hello everyone. I am VC Sridharan, Assistant Professor from the SNS College of Physiotherapy. In this video, we're going to see about the topic which is known as the Parkinsonism. Generally, the Parkinsonism is nothing but disease, a neurological condition which is mainly affected in the basal ganglia, which it is present in the base of the brain. So, the pathophysiology for the Parkinsonism is unrevealing the neural degeneration. So, in this Parkinsonism condition, the main cause that happens in this condition is nothing but the neural degeneration. So, this neural loss leads to the profound depletion of the dopamine, a critical neurotransmitter. So, due to loss of this dopamine, it results in the dopamine deficiency, severely disrupts the finely tuned basal ganglia and motor circuits, which are essential for the initiation and the modulation of the voluntary movement. So, due to this condition, it may lead to the motor symptoms which are observed in the patients, such as the patients have been shows the clinical features as asymmetric resting tremor, muscle rigidity and freezing of gait and reduced arm seam, and the facial expression looks like a mask-like structure and it also have a postural instability. So these were the hallmark pathological features that present in the Parkinsonism conditions. So there are these abnormal intracellular inclusions are primarily composed of the aggregated alpha synchrine proteins. The accumulation and the misfolding of alpha synuclein are thought to play a central role in the neurodegeneration. So now we're going to see about the what are the cardinal motor symptoms of the Parkinsonisms. So the main motor symptoms are nothing but the resting tremor. So tremor is nothing but the involuntary rhythmic oscillatory movement which happens affects the all limbs of the body. So it often presents in the distinctive pill rolling movement of the finger, and second one is the bradykinesia. So brady means slowness, kinesia means movement. So the patient who are all affected by the Parkinsonism may leads to the slowness of the movement and the reduction in the amplitude of the repetitive movements. These finds and this manifests a difficulty in initiating movements and decrease the spontaneous movements. So this may leads to the freezing of gait. And finally, third symptom is nothing but the rigidity. So rigidity is nothing but the refers to increase in the muscle tone. So due to increase in the muscle tone, it results in the resistance of the passive movement of limb. It can be uniform throughout the range of motion, often accompanied by the voluntary movement in the contralateral limbs, which is called as the Frenkel's maneuver. And the final motor symptom of the Parkinsonism is nothing but the postural instability. The impairment of balance and the coordination leading to the increased risk of falls. These symptoms typically develops the disease courses and it often resists the dopaminergic medications. And what now we're going to see about the non-motor symptoms. So non-motor symptoms are nothing but which are in non-involvement of the muscular system and the skeletal muscular systems, and as well as also neurological systems. So first we're going to see about the olfactory dysfunction. So olfactory dysfunction, here what happens, right? The condition is known as the hyposmia. So hyposmia is nothing but the reduced sense of smelling, which can be precede on the onset of motor signs by the ear or even more the decades. And second, we're going to see about the REM sleep behavior disorder. So this is characterized by the vivid, often violent dreams that are acted out due to the lack of normal muscle paralysis during the REM sleep. Then we're going to see about the autonomic dysfunction. So autonomic dysfunctions, which are nothing but the functions which are happens or the responsible by the autonomic nervous system, which are included as the chronic constipation, urinary urgency or incontinence, and the orthostatic hypotension. So next and the final non-motor symptom is nothing but the neuropsychiatric symptoms. So these neuropsychiatric symptoms which encompasses a range of cognitive and emotional disturbances. Depression and the anxiety are highly prevalent, often appearing clearly in the disease course. Though so, this cognitive impairment and ranging from the mild cognitive deficits to the dementia. So dementia is nothing but the precarious stage of the memory loss can be also developed, and particularly in the later stages. Now we're going to see about the different diagnostic approach for the Parkinsonism. So first we're going to diagnostic by the clinical assessment method. So in this clinical assessment method, we're going to take a detailed history of motor and non-motor symptoms and their onset, prognosis, and the any other factors that exacerbate or the levitate the normal condition to the higher or the chronical stages. So the comprehensive neurological experiments performed to identify the cardinal motor signs, which are tremor, rigidity, bradykinesia, and finally the postural instability. Second, we going for the radiographical imaging. So here in the radiographical imaging, we going to use about the DAT scan. So DAT scan is nothing but the dopamine transporter scan, which can provide the supportive evidence. So this DAT scan measures the integrity of dopaminergic neurons in the striatum. The reduced uptake of the tracer is consistent with the dopaminergic degeneration seen in the Parkinson's disease and the atypical Parkinsonism. And we next we going to identify the red flags for this Parkinsonism condition. Are so in this condition, the red flags are nothing but which includes early and severe autonomic dysfunction, rapid progression, prominent early falls, lack of response to the levodopa, or the significant neurological deficits like supranuclear gaze palsy and the cerebellar signs. And this final diagnostic approach is nothing but the monitoring and progression, and finally leads to the treatment responses. This diagnosis process often involves the observing the patients with the symptom progression over the time and their response to the dopaminergic energy. Here, the main monitoring progression and the treatment response is for the Parkinson's disease is nothing but they are often referred to the levodopa challenge or the levodopa responsiveness. Lack of significant response and the paradoxical worsening with the levodopa may prompt reevaluation of the diagnosis. And here we're going to see about the treatment strategies that have been used for the Parkinsonism conditions are. So first, the treatment strategies by medically which are known as the levodopa combined with the carbidopa. And second one is dopamine antagonist. Third one, MAOB inhibitors. Finally, COBMT inhibitors, anticholinergics. Anticholinergics are nothing but which can help in regaining their cognitive impairment. And amantadine. Amantadine is nothing but used for reducing the dyskinesis, deep brain stimulation in higher and the chronic stage. It is a neurosurgical procedure which helps in stimulating the areas of the brain. And finally, the advanced therapies are nothing but the levodopa, carbidopa intestinal gel delivered via the jejunal tube and the apomorphine infusions. These are the options for the patients with the severe motor fluctuations and the dyskinesis. So this is the overall overview for the Parkinson's condition. So on the next video, we can see about the some other topic. Thank you.